I'm going to give you a commercial break from the virus, HIV, but not so far away from it. So I'm not from the HIV world, as you can see. I've been listening very carefully and learning a lot and actually realizing the convergence of our health problems and how we share so many common features that can be used to strengthen the health system, especially in this part of the world where we have a high burden of disease from all kind of causes, and environmental and otherwise. So if I may move this forward, I hope this is forward. Yes, so I have no conflict of interest. The outline is going to be a little bit about the burden, and then I go to the framework and strategies for prevention, then just the links between non-communicable diseases and HIV. So this is what we normally use to describe the axis of non-communicable diseases. The major non-communicable diseases are basically 5. Until last year, there were 4, which are responsible for more than 3/4 of global mortality from NCDs. And these are basically cardiovascular disease, which takes the lion's share, about 50%, and then cancer, chronic respiratory diseases, diabetes, and more recently, very well-defined mental illnesses. And about 5 environmental and behavioral risk factors account for, again, more than 3/4 of these problems. They may seem very easy to deal with, but these things are a nightmare because most of their drivers are outside the health sector. And then we have the many other diseases that are associated with the key non-communicable diseases called the NCD comorbidities. And you can see it's the whole gamut of medicine in its totality. So this, unfortunately, is the new feature of African men and women. And Africa is an interesting continent. They are due in 9 months' time, I hope, but they never quite deliver. So Africa is a very interesting continent. There are problems of food security, and at the same time, we have this kind of human beings. So we have a serious double problem, even in nutrition. So the foods that we eat kind of reflect on that. The high salt, high sugar, high-fat food, which is less in vegetables and fruits, which we've really run away from the natural food that we used to eat quite some time ago. And if you think that it's just that, the quantities also are a problem. So some cultural beliefs and some ways in which eating habits can be quite a problem. Okay? So this younger brother of mine, this is one of our weaknesses. This younger brother of mine from Kenya, at least even at the age of mid-50s, keeps fit. So this is one of the things that we ask people to do. You may not have the equipment, but just being physically active. Exercise and physical activity are 2 different things. So an active phase of life is busy disappearing. There are very many motorized transports, motorbikes instead of cycling, and lots of things that really move us away from physical activity. Our kids are playing computer games instead of playing with toys that we used to play to, especially in modern areas. So there are many cultural changes that are driving NCDs. And then the problem of alcohol in our environment also is a big problem. And this is the saddest situation. A lot of tobacco companies have been smoked out of Western Europe and USA and have pitched tent in Africa. And some of the highest rising rates, incidence of smokers are actually educated women and our school children and college children. So I think this is a big problem that is contributing to NCDs as well. So the causal chain is that if those behavioral risk factors which I've just described here persist in a community or society for 5 years or more, you begin to see a lot of obesity, you begin to see a lot of hypertension, you begin to see a lot of diabetes, you begin to see a lot of cholesterol problems. And if this persists again for some time, then you begin to see people coming with stroke, heart attack, heart failure, kidney failure, to mention just a few, and cancers as well. So it's a cascade of events, really, that takes place in our society. And it doesn't choose whether you have HIV or you do not have HIV. So it's a societal problem which cuts across all society. So the global situation of NCDs, I would just like to emphasize something here. Just look at the burden, the mortality, excess mortality of people, premature mortality, people less than 70 years of age in totality, before you start even looking at the causes. So group 1 diseases are communicable diseases, maternal and perinatal nutritional problems, and group 2 are our NCDs, largely preventable, the red one. So I'd like you to pay attention to the red one. And you can see majority of this mortality is seen in low-income countries and low middle-income countries as well. And this is a place where you still have a bit of a problem with communicable diseases. So you have what we call a double burden of disease and a high burden of disease and a high mortality, which requires a health system approach which should be a little more innovative and should be very, very efficient to be able to deal with this problem, because resources are also scarce, both human resource and resource from technology and medicines in this part of the world. So we look at, I'll skip all that, I've already said it. Look at the regional situation of NCDs, and you can still see that communicable diseases, and HIV in adults takes a big chunk of this, are still the biggest killer. And you can see that about a third are now due to NCDs. And this has been changing for quite a bit and changing at a very fast rate. And this is the alarming part of NCDs. So if you look at the deaths attributable to NCDs in sub-Saharan Africa over time, this has been increasing quite steadily. And you can see that in 1990 it was about 25%, 2015 is about 15%, and majority of them, unfortunately, are due to cardiovascular disease. Then we look at the disability-adjusted life years as a measure of morbidity, and same problem, cardiovascular disease increasing quite a lot, and mental diseases as well. So I'll go quickly because I want to concentrate more on the integration. And the leading risk factors. Among cardiovascular disease, hypertension is a particular problem, and metabolic factors. That's why I emphasize diet, weight, and physical activity as a big menace in this part of the world, an increasing menace in this part of the world. So if you look at between 2005 and 2015, a period of 10 years, the largest increase in mortality from NCDs have been found in sub-Saharan Africa, where it is about 1.5 times the increase in the rest of the world. So this is where the epidemic is slowly emerging of NCDs, a region which is still raveling, as you well know, and that's why we are here, from infectious diseases, especially HIV. Then this is a health sector plan for Ministry of Health in Kenya. These were their projections in their health sector plan. If nothing is done about non-communicable diseases, this is the trend, unfortunately, that is occurring. If we hope that this is true, that communicable diseases will continue to go down if we put our efforts the way we are putting. But if we do nothing about non-communicable diseases, by 2025, they will take over from communicable diseases and become the biggest killer. And if you look at that, the number of deaths is just unacceptable. It means the total number of deaths will be increasing instead of decreasing. So, in summary, NCDs are actually the biggest killers in the world, especially in Western Europe and in the Americas, and also now in the Asias. In sub-Saharan Africa, we still have the double burden of disease, but the trend is such that in the next 7-10 years, if nothing is done, then we are going to have a major problem. So, unfortunately, NCDs are very expensive diseases. They're very crippling. They stay with someone for a long time. They're very expensive. So they're a big economic problem. And they actually have been shown from the Lancet Commission, the relationship between poverty and NCDs is terrible and can actually slow down the GDP of these countries if nothing is done. They are also undermining the SDGs, because if you look carefully, most of the drivers are actually outside the health sector, and they have a very, very complex interplay, such that a majority of the SDGs will not be achieved if we don't deal with NCDs and health in general. And then, of course, they also amplify societal inequality because of the healthcare systems that we have and the health financing system and universal health coverage that we are trying to really work hard about, which has not been achieved in many of our countries. So the main problems are CVD, cancer, diabetes, chronic lung disease, and mental illnesses, and those are the main risk factors listed there. So over time, a lot of global and national political activities have taken place, and I've just tried to summarize here. This is the first time that a major meeting since HIV, a major United Nations meeting has been done because of a health problem. And through time, we've been reviewing. In 2014, we reviewed the action, and around this time, some key action and accountability plan was done, what we call the 25 by 25 goals, to reduce the mortality from NCDs by 25% by the year 2025. And I'll just show you a few details as we go ahead. So then we had the 2030 agenda some years ago, and last year in September, we had another United Nations high-level meeting on NCDs in New York, where more commitment of resources by heads of state and linkages between NCDs and SDGs was emphasized. So according to this plan, 22 by 25, we have these 6 objectives: to make prevention and control of NCDs a priority, to strengthen the national capacities, reduce the modifiable risk factors, strengthen the health system, promote quality research and monitor trends, and generally have a 25% reduction of death of people between 30 and 70 from CVD, cancers, diabetes, and chronic lung disease. And these are specifics relating mostly to behavioral risk factors and biological risk factors. So you look at one here, which is really common with HIV, establishing at least availability and affordability of technology and medicines to treat the problem. And the rest, I think we can just go through. And these are some of the worrying things. NCDs constitute a public health problem that undermines social and economic development. And this is the amount of money estimated in loss of productivity, $7 trillion in the next 20 years if we do nothing. And this is the cost of doing something. The difference is just enormous. So the Agenda 2030, which you're all familiar with, accounts, here is where we have the health concerns. And if I move forward, this is where NCDs fit. But if you look carefully, most of the drivers of non-communicable diseases are all over in all the 17. So our attitude is, and also for HIV to some extent, our attitude is we strengthen the health system to deal with, we invest in the health system to deal with health, but also mainstream health in all the 17 goals. So that health becomes mainstreamed when you deal with infrastructure, when we deal with climate change. So health is actually a pan-SDG affair. So how about relationship between HIV and NCD? NCD in HIV can occur in patients who already have HIV and did not have NCD over time. You can also have patients who had NCDs and developed HIV, and then you have people who are diagnosed with both at the same time. Does it matter? Yes and no. When you come to treating them, maybe it doesn't matter, but when it comes to control or health system approach in identifying them, then it matters. That's why health promotion, when we talk about screening, linkages to care, if they're done simultaneously, certain aspects of HIV which have so far not done very well, and certain aspects of NCDs which are definitely not doing very well could be better addressed if one answered some of these questions and had a health system that takes care of all these 3 people. So AIDS-defining illnesses, this is just to go through some experiences that I've had with my residents in Aga Khan University, where I was for about 10 years. And AIDS-defining illnesses are still accounting majority of the admissions to critical care units. People are unwell, morbidity. But if you look at the outpatient department, the story is different. There are more and more proportions of people who have HIV and they're well controlled and their problems are really interesting to look at. If you look at respiratory system, if you look at incidence of cancers, if you look at the cardiometabolic states of these patients, you'll find that a good proportion of HIV patients, either incident or already on antiretroviral treatment, have a certain degree of NCDs, which, if not attended to, become the major cause of morbidity and mortality in the long run. And this needs to be curbed because NCDs, once entrenched, have a very high mortality. Just for your information, heart failure, for example, has the highest mortality, higher than any cancer, once clinical features set in. 50% of them are dead in 5 years, irrespective of the highest technology that can be applied. So it's better prevented than treated. So cardiovascular disease, unfortunately, contribute for the highest problem in HIV. So we look at a silo system that, unfortunately, has been propagated by the donor community. Malaria programs, TB programs, HIV programs, reproductive health programs, and now NCD programs. So same problems, same people, but different doors, which is part of our health system problem. So we had a project which we initiated about 2013, supported by PEPFAR and also NIH and Fogarty. I was fortunate to sit here and also participated in a lot of this. So our idea was to have a look at the PEPFAR system, which actually has shown most of sub-Saharan African countries that it's possible, with commitment of resources and political commitment as well, to be able to have a program that produces results and can be monitored well, and actually a model of a chronic care system. So we finished the program, and last year in the Amsterdam meeting, the AIDS meeting in Amsterdam, we actually had a symposium on it. In July, we published a supplement of the AIDS journal I would ask you to read. We have about 13 papers which look at the science of integration of HIV and NCDs, and some of the good points and some of the unanswered questions, and suggested research platforms on integration between HIV and NCDs at various levels. So we look at the common challenges faced across the health threats, desired demand-side barriers for HIV, diabetes, CVD, and you can see that they are uniform in most of these healthcare systems. Inequitable availability, health worker shortages, lack of adherence support. So most of the problems are quite common, but I would like you to pay attention on stigma and discrimination. And this is where I think a win for the HIV program can occur in integrating the two systems. We have some pilots which have been done, and I'm sure people in the audience here have also participated in some of the pilots, where dual screening and linkage to care of hypertension, diabetes, and HIV show some promise of feasibility. And with task sharing and also strengthening the protocols, one can be able to make it feasible and sustainable. Leveraging the lessons of HIV. HIV definitely is a leader compared to NCDs. So diagnosis and enrollment, retention and adherence, the multidisciplinary focus, family focus care that I've had most of yesterday and today, and the linkages and referrals, the self-management, making the patient actually have capacity for self-care, and the community linkages, and most important, partnerships, both national partnerships, and multilateral partnerships with the organizations in the private sector, and also other governments are quite important if we are going to solve these problems. So primary care integration is very, very important, and this is where I really focus. Most NCD focuses on primary care, prevention and primary care, because this is where the best buys, the WHO best buys are found. $1 injected into the healthcare system will produce better results if it's dealing with prevention and primary care than tertiary care of very complex cancers and cardiovascular diseases and respiratory problems. And therefore, primary care is really the problem. And this just shows an example of a modification of a triage system that we had done in a health center, where you could do cholesterol, blood sugar, BMI, blood pressure during triage in a CCC, the comprehensive care clinics, where also they could do viral loads, liver function tests, and urine and electrolytes using point-of-care equipment, and really integrating the system quite well. The economies, we also had a paper on this, on the economies of integration, and there are very many questions which really still I need to answer if we are going to integrate the two systems, so that we don't roll back the gains that HIV programs or the PEPFAR programs have attained in the last more than 15 years. So we need better evidence on cost and cost effectiveness and fiscal sustainability of these integrated programs. And one of my good friends, Rachel Nugent, is quite committed to doing studies on this, and there are some pilots also which have been done in costing some of these programs in various countries. So behavior change communication, which has been quite good with HIV also. We reviewed lots of papers, especially in sub-Saharan Africa, on programs which integrate behavior change communication at all levels, from counseling for adherence all the way to health promotion. And again, we did find that the studies are quite few, quite scattered, and their evaluation was quite wanting. So this is one area of research also, integrating behavior change communication and health promotion for HIV and NCDs is really something that we need to do and can be quite cost effective at that level. This is just a session with the community health volunteers who were involved in health promotion for both HIV and non-communicable diseases at that level. Thank you. So partners and coverage, this is a slide which you are more familiar with than me. And the same models are actually being used for NCDs, and we're asking ourselves, do we need to duplicate? Because if the sources are the same, do we need to duplicate partners? And do we need to ask the same partner the same question twice from an HIV point of view and from an NCD point of view? So investments in HIV response have laid a very good foundation for quality of HIV and NCD integrated care. And because of time, I'll not take you through all that, but you can see the investments in the response, and you can see some of the systems that are put in place and the quality of care and how we can be able to integrate the systems. The chronic care model that I've talked about, the end result being here, an informed, activated patient and a prepared and proactive team and the interactions that take place. And I think this can happen for both HIV because the elements are actually duplicate. So approaches to health system integration, there are very many approaches, and one can think of horizontal blocks, like I've just talked about, HIV and TB, which you've done, HIV and MCHFP, and then pan-horizontal, and then you can talk, the most important is actually diagonal approaches, because this is where resources really are duplicated and wasted. Human resource development, we talked about task sharing, financing and planning, drug supply systems, which really don't need to be duplicated, quality assurance systems. Then there's total integration, which WHO is actually advocating for ICC countries in transition. So one of the effects of total integration is actually looking at the upstream drivers of both HIV and NCD, which lie outside the health sector, and making sure that we involve multiple sectors and we do mainstream health into the national development programs and position health not as a cost, but an investment case in the human development agenda, both at national level and at global level. And this is where the agenda of SDGs, I think, puts us, and the issue of universal health coverage, which we are going to be discussing in September in New York at the UHC conference. It's better if there were plans of mainstreaming health, be it HIV or an NCD, than approaching health in silos and ensuring that there is an element of health in all these SDG goals. And that's really the message that we are trying to portray here. So the journey to UHC is here. This is the plan that we're going. So I think we need to work together and find mechanisms of working together. So the science of integration, integrating HIV and NCDs, and partnerships that do this at national and at global level, I think are key if we are going to win the UHC war and also the war about SDGs and health in general. Being only in Agenda 3 is not a handicap. Thank you. So 5 concluding remarks, which I think we can all read. Strengthen action on SDGs, integrated approach, mainstreaming health, positioning health not as a cost, but an investment in health because of the relations between health and poverty, especially in low and middle income countries where resources are few, and achievement of UHC through primary health care strengthening by integration. And we need a lot of evidence base in research. I heard about implementation science, and I was very excited because that is one of the best tools to use to study integration of HIV and NCDs at all levels. Thank you.